On staffing for utilization management. This webinar is a follow-up to last week's overview for and again, we'll focus on the staffing component of this. Let's just move the slide here. My name is Boris Kilgorin. I'm the Healthcare Strategy Officer at the McSilver Institute and with MCTAC. And before we really jump in here with learning objectives and the presentation, just some housekeeping, just to mention that all of the presentation will be emailed to all of the participants, but it's also going to be posted on the MCTAC website, and the information on the MCTAC website will be at the end of the presentation. So again, we will be emailing this out and posting this presentation. In addition, just to underscore, today's presentation is a brief presentation meant to be around 15 or so minutes. Today's session is really meant for all of you to be able to ask questions and have a discussion in regards to utilization management. The way we will do this is through the chat option. So if you look at your lower right-hand corner, you should be able to see an option to type in your questions. And as the questions come in at the end of this presentation, I will read the question and try to answer them. All right, so with that, let me jump into the learning objectives and, again, a brief presentation on the staffing. So today what we want to do is make sure we understand what focused staff positions are, learn from experience of other organizations. So if there's anybody at the end of this that would like to share their experience, that would be great. Again, more than happy to read those chats or texts. And also, of course, as I mentioned, help to, ask questions that will hopefully clarify the way forward with some of the staffing. Okay, so just a quick overview, especially for those who might have not participated in last week's session, and just to make sure we're all on the same page. And that is, let's start with what is utilization management. So it is a process that is used by managed care organizations to decide whether a specific healthcare service is appropriate, if the level of care is appropriate, and it falls under the coverage. And one of the key components of it is, as you heard last week and we'll be hearing throughout the managed care implementation, is of course the medical necessity, meaning is this service medically necessary and appropriate, and of course is it cost effective? And is this the least restrictive level of care, meaning that is there a way to deliver the service or the need to meet the need of the individual health care at a lower level of care? And so one of the questions that we get and that comes from all of this is, what is the difference between utilization management and utilization review that a number of agencies through regulations or through their own means are doing? So one is utilization review is a regulatory requirement, and it's an internal review. And utilization management is the managed care standard, and of course external. So the big component really is, in utilization management, you now have an external entity, which is a managed care organization, that is part of that review process, and the one could potentially direct the decision making, versus utilization review is an internal process. And of course, the goal here is to maintain integrity of the services. So let's jump into the preparation checklist that I know John Lee went through last week. Again, this will focus on the organizational structure and the utilization management staff. This is not the entire checklist. This is a subset. And so the questions that agencies, organizations need to ask are, staff, utilization management staff members, should be an active part of the treatment team. As they communicate with managed care companies, they need to understand the treatment, what has been proposed, why it has been proposed. and they have to have workspace in proximity to service delivery team. So one of the issues that sometimes come up is the location, where sometimes the utilization management staff are not near the service delivery. In some instances, it's impossible, especially in the large systems that are spread out. But as much as possible, if a staff could be part of the treatment team and literally located near the treatment team, that is, of course, the best options. But understanding that that's not always possible depending on the provider. Of course, it goes without saying, and we'll go through the requirements or recommended requirements for hiring staff, but they should have an expertise in behavioral health, hopefully physical health, and as HCBS becomes part of the system, understanding HCBS services, they need to, of course, understand the managed care language, the managed care criteria, the expectations, and as levels of care is one of the things that's going to be available and published in the near future by managed care companies as the level of care. The staff would need to be very familiar with those determinations and those criteria, and of course participate in case studies. Practice offering justification in a manner that reflects the MCO requirements. So at the end of the day, what you want is the staff that when they call the managed care company, they can speak that language, they can explain it, and really justify the services that are required, and be able to understand internally and then translate back to the treatment team and to the service area of the managed care requirements, and making sure that all are on the same page and not working against each other. So, of course, I believe in 2 weeks or so, there's going to be a session, a webinar that's going to focus on the supervision of utilization management, so I'm not going to spend too much time on it here, but of course, staff needs to be supervised and have a direct supervision of an individual who is also familiar and knowledgeable about But as I said, there'll be a specific webinar that's going to focus on the supervisory responsibility, and we'll go into a much more in-depth discussion. In this webinar, what I would like to do is focus more on the staff and what their responsibility are. So this is just, again, as this is going to get emailed, this is for you to utilize as a suggested job description for utilization management staff. And here are just blown up those components from the previous slide, which we'll keep repeating in the communication, being the number one bullet of being able to talk to the managed care company. And of course, that comes with a lot of usual staff requirements, being positive and professional, understanding the practices, understanding their job, and being able to negotiate. And negotiate not only with the managed care company, but also negotiate internally with the system, and being able to serve as a bridge between the two entities, both, again, the ones who are providing the service and the managed care entity. Available for case conferences, care plan strategies, and any other strategies that and requirements that might come up. Some of the qualifications for the staff that are preferred but not required, of course, is a registered nurse, a licensed professional with certificates or expertise. Again, depending on the service, depending on the level of care, it might vary of what might be a better qualification, since we're talking in the current system, everything from inpatient to partial hospitalization to PROs to clinics to opiate treatment programs, to substance abuse clinics and so forth. They might need to be different qualifications. What you want to make sure at the end of the day is that the person who's doing the utilization management for that particular program is qualified, and when they're talking to their counterpart at the managed care company, they're at a same or very close level of certification, licensure, and expertise. Of course, if you can obtain somebody that has a current experience in utilization management, that's always preferred, but that might not be always possible. Person-centered, recovery-focused approaches, and again, understands the managed care outcomes requirements, but also understands HEDIS. So for those who might not be familiar with HEDIS, HEDIS are measures that measure managed care companies and their outcomes, and are tied into basically healthcare measures. In mental health, for example, there's a measure of post-discharge hospitalization and the requirement of seeing somebody within 7 days. That would be an example of a HEDIS score that goes into thinking of utilization management, and staff who are dealing with this should be familiar, not with every necessarily HEDIS measure, because there's a lot of them. Most of them are on the medical side, but definitely the HEDIS scores of the behavioral health and any related HEDIS measures in an integrated model. And of course, all the other qualifications that come with, again, with a typical job description or that you would be looking for any staff. So with that, really, again, this was meant to be a brief overview and a repeat with a little bit of focus from last week. What I really would like to do is open the floor for questions and hopefully answers, and bring folks in and welcome folks to type in their questions into the chat. So I'll open the floor for any questions. Okay, so while we wait for folks to type, I'll throw something out there that I know sometimes is confusing. I know there might be a number of folks that are part of utilization review and currently do utilization review, and might be thinking about what does this mean to me, or an agency, again, that does internal utilization review. I know John talked about this, but again, I can't emphasize enough of how internally the organizations need to take this information and start building and thinking through what does this really mean for an organization, what could it potentially mean to some of the staff who are currently doing similar jobs, potentially like utilization review, or does this mean bringing on a number of new staff at the same time? So that's one kind of theme that keeps coming, but it really is up to agency structure and agencies thinking on how to approach this. So we have a couple of questions. So there's a question on why an RN for the staff. So it does not have to be an RN. It's one example of a staff qualification. And again, depending on criteria. So for example, in mental health clinic, where some of the services that are provided are medication or more medically based, depending on the discussion, instead of having a doctor call in, sometimes a nurse could be used in having those discussions on the medical end. That's just one example. I know in the partial programs, again, that could be utilized, but it's definitely not a requirement and might not even be appropriate for all levels of care. So let me scroll back up. So is there a tool you can recommend to calculate the case staff ratio? I am not familiar with any particular tool, but I would definitely take this back to our folks internally, see if anybody else does. And one of the things we're actually in the process of creating is an FAQs for the component, and we'll put that as one of the questions and see if we can come up with some recommendations or point you to any tools. So also be on the lookout for the FAQs that will incorporate all of these questions, and especially any questions that I was not able to answer at the moment. Another question, will the state agencies be included this type of staff in their budget requirements, and will they recognize the need for funding these positions? So I think, as I just mentioned, I think every agency, including state agencies, needs to have an internal discussion on this. Every agency, state, non-for-profit, or otherwise, are in different places, have different staff currently, have different structures. So there's really, unfortunately, not one answer. But what needs to happen is a recognition that this function needs to exist. Somebody needs to do this. How it gets built and completed, it's really up to each agency. But the first step is really recognizing the need to really have somebody responsible and focused for these functions. Let's see, there's another question. For inpatient rehab substance abuse, what should be the client to our staff ratio? So I'm not sure if it's, that question is more generic in regards to providing services. I am not, if it's related to providing services, I am not familiar. I would suggest looking at the regulations and checking if there's any requirements. If it's related to the client to ratio, again, we're going to post that on our FAQs and look to see if there's any guidance or any tools that we can direct you in regards to determining that. What credentials can we expect from the managed care staff to have? Similar to what you should have, it could range from licensed social workers to registered nurses to bachelor-level rehab and recovery staff. Managed care will have staff that will have the right expertise and the right level of credentials to be able to do utilization management. Again, more clinically, medically, services that lean towards that will most likely have licensed social workers or registered nurses. Services that are recovery-based might have other types of staff. And again, the job of each agency is to make sure that when you're talking to the managed care staff, that those kind of qualifications not necessarily always meet to the T, but at least the individuals can talk at the same level. Another question, what trainings are available for organizations that may want to develop and train in-house staff, and where are the best places, website except for recruiting staff with required skills and experience? So I am, besides the usual recruiting places, not familiar, but so again, we'll take that back and see if there's any direct, recommendations we can make to the websites for recruitment. In regards to the training in-house staff, what we as MCTAC will continually do here internally is as information and utilization management becomes more available, we're going to be providing more training, especially on levels of care criteria and other criteria, also tools on it. What I would suggest that, again, that you as an agency identify individuals who might become your experts or in-house trainers who attend these trainings, get familiar with all the documentation that's available, and slowly develop those skills that they can become the in-house trainers. If there's anything else that's available that's out there that folks can participate in, we'll definitely post that on our FAQs as well. Okay, we have another question. What trainings are available for, same question. So there's another question on the ratio. Again, the ratio questions we'll research it internally and answer. I don't think there's necessarily a magic number. And again, for different types of services, I suspect will be a different ratio requirements for ambulatory versus inpatient versus partial and so forth. We'll do more research on our end and see if we can provide any guidance. Can the intake staff fulfill the function of UM? In some instances, it is possible, usually at a clinic level at an intake point. At some of the other types of level of services, it might not be possible. You also have to consider the time it might take to do utilization management at an intake level, or depending on your staff who currently does intake and what their credentials are. So again, this goes back into focus and specialty. You know, there's a need to utilize internal staff or will to utilize internal staff, which is fine as long as the individual meets the requirements. I think one of the questions agencies need to ask themselves is this a one-person job, meaning intake and UM, or two, or will this require two individuals to complete this job? And again, it's agency by agency specific. It depends on the impact of the managed care transition, the volume of what's going to happen. For some agencies, one person might be able to do this if the volume is small enough, and for others, it might require a team depending on their need. Okay, there are more questions. Are there UM organizations you can outsource this function to? I believe there are a few. I'm not familiar off the top of my head. We'll research that, see if there's any UM organizations. My only, I guess, caveat to outsourcing utilization management, which goes back to being able to be part of the team, being able to understand the treatment, being able to negotiate internally in the agency as well with the managed care company, and being as much as possible in a close proximity is important. And with outsourcing utilization management, sometimes those are challenges and could be potentially barriers if it becomes more of just a mechanical task, rather than really being part of the team, representing the agencies, and being able to negotiate both internally and externally with managed care companies. But with that being said, we will look to see if there's any UM organizations out there, and if there's that we can point you towards. How will programs agencies be made aware of the requirements of what staffing is required for your team? So the utilization, I think this is about really utilization management. As far as I know, there won't be any requirements of what staffing. This is going to be more for each agency to determine. I think as the clinical criteria, level of care criteria, and the criteria on utilization management from the managed care companies become available, each agency, based on the services they provide, the contracts, will need to review that and decide what type of staff they need to meet those requirements. But as far as I know, there won't be an official requirement to, one, have utilization management staff, and two, on what level they should be. Okay. More questions? Will this position be incorporated within the civil service portfolio? unfortunately, that's outside of my area of expertise. We'll post that to our state partners and see if they can help us answer that question, and we'll put that on an FAQ. Okay, clarification. With 1,500 outpatients, how many UMSTEP would you recommend? I feel like this is a math problem and maybe even a trick question. Would it be 500 patients each at 3 different sites? So again, I'm not sure if there's a magic number to this. One is not every client that you're currently serving will be transitioning to managed care, just to underscore that, for example, duals, individuals with Medicare and Medicaid, would not be in the transition. So each program and agency needs to determine the impact of this transition. 2 is as utilization management criteria and rules come out from managed care companies will also dictate of kind of the intensity and the staffing that's required. So just to give an example, many years ago in the mental health clinics, a lot of managed care companies did authorization for every 5 visits. You have to, every 5 visits, get another authorization and fill out a form and do something. That was a pretty intensive process. So when you had 500 clients with a managed care company, and every 5 visits you had to do something, that was pretty intensive. Over the years, that requirement went down or went up, depending on how you're looking at it, to 20 visits, which required many less staff to handle the same amount of clients. And over time, most managed care companies these days don't even require any credentialing. So the ratios and how this would work, it's hard to tell at the moment. 1, it's program specific. 2 is how many staff are impacted by this. And 3 is what are the regulations and rules that are going to be posted. When that becomes more available, especially the 3rd one, in regards to the rules, some, thinking about how many staff you might need might get developed and maybe some rules about it. But we'll be on the lookout for that to see if there's any learned experiences from other organizations, or if there's any learning collaborative we can do in the near future that maybe can help folks talk amongst themselves to determine what would be the right staffing pattern. But until we know the true intensity or requirement, it'll be very hard to determine these ratios. Moving on with the questions, what position would you suggest a UM supervisor report to? The clinical director, executive director, or board of directors? I'm not sure they should be reporting to the board of directors. And I think, again, I think this is organization-specific decision. In large organizations, it might be to the clinical director or maybe an operational person. And in other agencies, maybe it's appropriate to report to the executive director. I think as you look at the structure, how many staff, where does it fit? I think it's important. I think it's also important to make sure that they're part of the treatment team and communicating part of it. So again, there's not one answer for every situation here, and every agency structure. Reporting is different, and agencies really need to think that through of what would be the best place for the UM supervisor to report to. Okay, another question. What position would you, same question, popped up for some reason. Okay, is it standard practice for existing clinical staff to take on an additional UM task and manage this effectively? I'm not sure if this is a standard practice. I know in some transition, again, when the volume and intensity is low in the beginning, and in some instances that is the way it starts, I have seen where clinical staff have taken on additional tasks, but those are usually as kind of implementation starts up, and some, the jobs are not filled yet, and there's no real understanding of the volume or expectation. In some instances, when there's there's going to be a lot of work, and this will require full-time staff, I think agencies have moved into hiring as fast as possible the new staff. So it all depends, but again, there are instances, and it might be even appropriate, I would say, if we're talking about very few clients, as the managed care transition starts, it might be appropriate. And then there probably reaches a point where a part-time or full-time designated staff might make more sense. So again, for internal discussions within programs and agencies. Okay. Let's see if there's another question. How do you foresee impacting peer services? That's an interesting question. So one is peer service is one of the HCBS services that's required, and as the rules about HCBS services and that's one way that could impact, because it is a straight, it's one of the services. Peers, as with many other services they provide, could help in both working with consumers, the providers, and the managed care companies to determine and work with determining the right levels of care and the right approaches. And I think that's something that still needs to be developed and really worked on, but I think peers could definitely play a role in some of this, and especially with the HCBS specific peer services. We have another question here is, will be costly. Providers will have to include this cost in contracting. It definitely can be costly, and it should be included in the business plan and in the budget. In regards to the contracting side of it, the rates are set by the state, so there will be the Medicaid rates, and I'm not sure if any managed care companies will go beyond that. I don't think they will, and I would suspect that that rate is all-inclusive, but this is a function that needs to be covered and should be covered by the providers. Okay, so that was, let me quickly just look through here, make sure that I haven't missed any questions. Again, both the presentation and this webinar will be posted. We'll be also posting the FAQs and some of the questions that I was not able to answer. Hopefully we'll be able to answer. Excuse me. So while we wait, if there's any more questions, let me just do a plug here for the upcoming events. So the next webinar would be on implementation, and implementing webinar will be next Monday, following by our fourth and final webinar on supervision, which would be the following Monday, the 29th. I also would recommend that if folks have additional questions, especially as they relate to the upcoming webinars, to submit them ahead of time if possible to mctac.info@nyu.edu, and please use the subject line overview if it's specific to that, but you can always send questions to mctac.info@nyu.edu at any time. Okay, while I was going through some additional slides and information on the question came in, should report to the compliance officer on a regular basis? Again, I think each agency needs to decide where should report to. You know, and depending on the structure and the responsibility of the compliance officer, it might be appropriate, and for others, it might not. So I think, again, it's really up to the agency to decide on the reporting structure. So while we wait for more questions, just want to remind folks to send in questions, and also that's again at mctac.info. And also, if I can move the slide, wanted to show our website. I know I referred to it a number of times at mctac.org. That's for the Managed Care Technical Assistance. And we also have ctacny.com, which is our Community Technical Assistance program as well. This presentation and webinar will be posted on the mctac.org website. I'll give it another minute for any other questions, and if not, we'll end the webinar at that time. All right. So since there's no additional questions, I want to thank everybody for participating. Hopefully this was helpful.